agenda today. So I think a few more people are still joining, but John, I think we'll get started on introductions and whatnot in just a few seconds. For those that are just joining, if you could go on mute and keep your cameras off, that would be great. We are recording this session, and if there's questions, you can certainly use the chat button, and there will be a time for questions and answers at the end. We are very pleased to have a very full schedule today. The first 40 minutes or so will be with Dr. Kvedar, and we'll introduce him in just a minute. And then the second half will be with a panel discussion about the concurrent COVID and non-COVID patient management in healthcare facilities, preparing for a potential second surge. At this time, I'd like to turn this over for a second to Richard Barnett, the founder of HAIO, for some brief words, and then John Meservey to introduce our first speaker, Dr. Kvedar. And thank you very much, everyone, for joining us this morning.
Thank you, Stan. I want to first of all thank you and Teresa Wilson so much for the continuing effort you have made, and everyone here involved to help us continue our mission in minimizing healthcare infections. We are truly looking forward to this meeting, and I want to introduce and thank my friend John Meservey, president of HAIO. John?
John, you may be on mute if
I was.
Okay.
Thank you, everybody, and welcome. It's my pleasure to introduce our first speaker, Joe Kvedar. I first met Joe about 10 years ago. Actually, it was through my wife. He was doing some work with my wife at the Partners IS department. If you read Joe's bio that was included in the package, the meeting package, you'll see that Joe is a professor of dermatology at Harvard Medical School. What Joe's bio doesn't mention is that he is a trailblazer in the field of telemedicine. If you look back, as I did, at some of the publications from 25 years ago, you'll see that the term teledermatology shows up in about 1995, and you'll find that one of the first articles about teledermatology was written by Joe. And Joe posited that, and this is to quote, "It may be possible for dermatology to shift from its traditional face-to-face model to an image-based, remotely practiced one." And that was in 1995. I mean, who even had a computer in 1995? So Joe's work was the seed, and what we've witnessed over the past few months in particular is the uptake in virtual visits. Is the tree bearing fruit, and I think for Joe it must be incredibly exciting to see this. But now my question is, Joe, what's next? To tell us what's next, it's my great honor to introduce Dr. Joseph Kvedar.
Well, thanks so much, John. Just doing a sound check. You can hear me all right, yes?
Yes.
Yes, thank you.
Good. That's always important. Slides alone don't do the trick. So I'm very excited to present to this group today. It has been an extraordinary ride the last 6 months. It was very much an inflection point for an area that I care deeply about, digital medicine writ large and telehealth specifically. And I'll talk to some detail about that in some of the updates that I'm going to give the group. I've tried wherever possible, knowing that there's a facilities bent to your organization and your interest, to think with you during this 45 minutes or so about how these profound changes will affect our use of facilities, and they will. I haven't gone into great detail about the infectious disease implications. perhaps that will come up in the Q&A and we can talk about that, but really more of a higher level view of this. And it really starts with me just saying a word or two about ATA. That's a major bit of my time these days, is the American Telemedicine Association. And just to say that it is really an amazing time to be in that organization and at the helm as we advocate for the whole, moving the whole industry forward. And it's been an amazing time in the last few months to be doing that and to play a role in national policy. I had the opportunity to testify in front of a Senate committee. We've looked at some of the policy positions of our presidential candidates and just really had an opportunity to have an influence, and it's been very exciting. This is a really important graph, I think, for this group to wrestle with, so I'm going to spend a little time and stick on the slide for just a few seconds, because independent of any pandemic, independent of any other things that you might be thinking about, this is real, that the supply of healthcare providers is being outstripped by the demand for healthcare services. This shows up, if you're a patient, it shows up in less time with your doctor. If you're a doctor, it shows up as physician burnout because the waiting room is always full and you could never get everything done. But the underpinning of this, and I think a really important reason that I bring it up here, is the notion that we can only conduct healthcare one-to-one. Now, I used to say one-to-one in the office. In the last few months, as I'll say more about momentarily, we've moved the doctor's office into the patient's living room, and everyone became comfortable with that almost instantaneously overnight, but it's still one-to-one. And one-to-one is very limiting. Other services that you consume are all one-to-many, whether it be a ride share like Uber, Amazon ordering your goods and having them shipped to your door. There are so many examples of this in the service industry, which have been motivated by the need for efficiency. We just haven't quite got there in healthcare yet. So a lot of my commentary is anchored in the need to solve that problem using the right technologies, the right place at the right time. And indeed, it does have a major implication for how we use our brick and mortar facilities as well. So to me, that anchoring is an important way to look at the rest of my remarks. Now, there's a famous quote. I never met Steve Jobs, but I've spoken to people before who knew him well. And there's a famous story that he was in the supermarket, I guess the day that his picture was on, I think, Time magazine, and ran into a friend, and the friend said, you know, congratulations, Steve. And the comment was, well, there's no such thing as an overnight sensation. And this is really true for telehealth as well. I'm going to show just two graphs about adoption prior to the pandemic, just to give people a sense that this was bubbling up around us in fits and starts over the years. So this one is Rock Health consumer adoption data. It's really not useful for you to read the whole thing now, but to focus really on the left-hand side, which is live interactive video. This is 2019 data. And you can see that in 2018 and 2019, roughly a third of the population that they surveyed had said that they had live video interaction with a healthcare provider. So that's not zero. And as folks from our delivery system know, we had a growing and for the time, relatively robust program going on in telehealth prior to the pandemic. These are AMA data on physician adoption. I spent many, many years championing adoption, trying to convince my physician colleagues that they should pay attention to this mode of care delivery, and largely getting a lot of shoulder shrugs, quite candidly. And this data reflects that. In 2016, the data, which are the blue bars here, these are, again, AMA data, and you can focus once again on the left-hand bars. There were 14% of physicians surveyed said they had some sort of digital health or telehealth in their practice. That doubled to 28% in 2019, which at the time we thought was an enormous victory. And then, of course, everything changed overnight, and March of 2020, and we all know that telehealth all of a sudden became a household word. We told everyone they had to stay at home. We told them that if they went out that they might catch this deadly virus. Of course, that's still in play, but as you know, particularly in Massachusetts, we found, I think, a very nice balance between telehealth and in-person care. And again, that balance, if we see that as our future, and many of us do, that really dictates, again, how we're going to think about our use of facilities in a new way. But in mid-March, we forced new workflows for patients and providers. We told our doctors that the only way you can really take care of your patients, unless they have a dire emergency, is virtual. We did that overnight. When you think about that, that's extraordinary. In February of 2020, across our system at Mass General Brigham, we did about 1,600 virtual encounters. By early May, it was up to 60,000 a week. And now it's settled back down a little bit. So 23-ish% of our ambulatory volume these days is telehealth, not insignificant. And many people expect that that's going to be the future. And of course, it will depend on some other things, which I'll get to in a moment, and are listed on the bottom of this particular slide. That is to say that this rapid growth was enabled in large part, not only by patient willingness and physician willingness to participate in a new mode of care delivery, but by these three regulatory relaxations in three categories: reimbursement, technology, and licensing. I don't expect that we'll cover all three in detail, but we will talk a little bit about each during the presentation. And so telehealth is now a household word, and we've brought the doctor's office successfully into the home. As an evangelist, as a forerunner, I can't really tell you enough how much that means to the industry, because it now allows us to enter any conversation in healthcare delivery and people immediately know what we're talking about and have some respect for this care modality that wasn't usually the case, not even always the case, even a year ago. And all of a sudden now people have had experience with it. Patients know what we're talking about. Clinicians largely are supportive. And we're now trying to figure out, again, what does it mean to be in a hybrid environment where we're doing telehealth some of the time and in-person some of the time. For instance, in my clinical practice, we're back at almost full capacity, meaning since we can't have people in the waiting room, we can't have any more than one person every 15 minutes in our schedule, so we can't overbook. And that leads us to doing a couple hours a week per doctor of telehealth. I'm doing my sessions this afternoon, every Tuesday afternoon. And it's for dermatology, it's largely sharing of images over the patient portal and then a telephone call. And it works quite well for a number of things. And I'm going to get a little bit later into some of the things that are good for telehealth and some of the things that are maybe not so good. So we're at a critical inflection point. Now, I said this earlier, if we don't get beyond this point, we really won't solve that one-to-many problem, but at least we're now part of the conversation and people take us seriously, and that just can't be underestimated, the power of that. So this slide I like because it doesn't just include healthcare providers. I used to have a slide where I listed a lot of the growth in these provider organizations, but if you look at companies, Zipnosis and Teladoc, you can see their enormous growth as well. That's largely through the health plan industry or through the employer part of the industry. So everywhere you look, people are adopting enormous amounts of telehealth. As I said earlier, it's gone through somewhat of a deflation in the last few weeks as we've gone back to in-person care. That's, by the way, no means a defeat for the concept. It simply is a equilibrating of what makes sense. As I said, not everything that we do in healthcare should be done by telehealth. So these are some trends to watch. I mentioned the regulatory equilibrium. So very quickly, during the public health emergency, the Centers for Medicare and Medicaid Services was able to put aside some of the statutory limitations they have on telehealth reimbursement so that any Medicare recipient anywhere can now participate in telehealth and the clinicians can be reimbursed. But parenthetically, that has to be worked on because it is statutory, it's not regulatory. And so there's a number of advocacy efforts in place to try to get that law changed. It's called the originating site rule. And I urge anyone to contact their elected representatives to remind them how important this is for our Medicare patients. Private payers have largely followed suit, many forced by their governors. So that's going to be interesting to see as the public health emergency is lifted. But telehealth seems to be now a part of the fabric of healthcare delivery, and whether it be 20% of visits or more or less, it's substantially more than it was prior to the pandemic, and nobody really sees that going back. To quote our own Medicare administrator, Seema Verma, this is her quote, not mine: "The genie's out of the bottle and I can't see it going back." The technology part here is really largely about HIPAA and about not exercising HIPAA enforcement during the pandemic, allowing providers to use all manner of technology. That's probably going to change, probably not that relevant to this particular audience. And then state licensure. 49 out of 50 states now have relaxed interstate licensure commerce rules to allow clinicians to practice over state lines. So we have a very positive regulatory environment for telehealth at the moment. And most soothsayers, because it really is about a crystal ball at this point, most soothsayers would say that it's not going to be quite this liberal, but it isn't going back to what it was before. There will be several technologies coming to the fore, and you can see them mentioned here: digital biomarkers, which are these software tools on your mobile device that do things like calculate based on the tone of your voice, all kinds of things, whether you're depressed, whether you're about to have a cardiac event. It's amazing what artificial intelligence and vocal tonality can do. There's a company, for instance, that can tell if by the sound of your cough what your respiratory illness is, just by the sound of the cough. Home devices and home lab testing, all those are going to grow. We're going to see more asynchronous care and more remote patient monitoring. And all of those trends, I think, are things you need to pay attention to. Each one of them has an impact on how we think about brick and mortar healthcare. So what is telehealth good for? Well, the top of the list is mental health. The physical exam in mental health is talking to the patient, and lo and behold, you can do that quite effectively through video. So I'll show a slide in a minute with some stats on which specialties are doing more or less telehealth. Mental health, though, even before the pandemic, was approximately 50%. Now it's up to 80 or 90%. Virtual urgent care is not new, but it's of course more prominent now, especially because a lot of the things on that list that you see there are COVID symptoms. So being able to screen patients for whether they need a COVID test or not using virtual urgent care has become quite popular. That's a lot of the growth that I shared earlier in the companies like Zipnosis and Teladoc. And then follow-up for chronic conditions. Those are the mainstays. Now, if we see more home testing, if we see more devices in the home, if we see more prominent use of those digital biomarkers, there will be more use cases that are legitimate for telehealth. But for now, it's really these three buckets. And then things that probably aren't suitable. Now, the first one I admit is controversial. I've had many patients share with me that their primary care doctors are doing annual checkups virtually. I suppose if you don't have a lot of need for the actual physical exam, depending on your preventative and chronic illness profile, and if it's largely lab test driven, I could see maybe doing it verbally. But I think that's a very much a judgment call on the part of the primary care doctor. Instances where you know a lab test or images are critical. So the last thing our payer colleagues like is if we do a virtual visit and we say, okay, now you need X, come to the facility and we're going to repeat everything and bill you twice. That's a big red flag. So if you know that's going to happen, we suggest that you just do it in person. Multiple chronic problems that require highly nuanced care and decision-making. Highly sensitive matters. Now, to me, that's another one that someone might argue against. I like to see people and look them in the eye when they have a new diagnosis of cancer or when we're making end-of-life decisions. We do those in dermatology from time to time, so it's not just theoretical. And then, of course, anything procedural. Now, this slide, I would urge you not to try to interpret the, it's a visual, not interpret the actual data on the slide, because this is about which specialties had fewer decline in office visits. But the way to look at it is as a barometer of where telehealth makes a lot of sense. So ophthalmology is at the top of the list because, frankly, there isn't much they can do by telehealth. There's mostly what they do is put people in machines, as you see pictured here. That has to be done in the office, which is why they didn't really do much telehealth during the public health emergency. And all the way on the bottom, you see behavioral health, which I mentioned is very telehealth ripe, and therefore very little change in their practice during the time when they couldn't come in the office. That's what this slide is about. So we've successfully brought the doctor's home, the doctor's office into the home. And I do, as I said, want to make sure that we don't ignore that beautiful thing, that now that is a thing, that people are comfortable with it. But that said, it's a very limited view of what we can and should do with these technologies. I mentioned asynchronous before. I've alluded to the use of front-end digital, like other service delivery organizations do. So many, if any of you have experienced tech support, and basically any of these companies now, you interact first with a bot, whether it be on the phone or on a chat on a website, and you get triaged to a human being if you need it. The companies that do it really well, for instance, Apple does a particularly good job of this. It's very seamless, and you go from the bot to the human being and feel well cared for. I think that's a model for how we're going to do this in healthcare. And then there are companies that all of us know where we literally tear our hair out because you're trying to get a hold of a human being and you can't get out of the phone loop or get away from the bot. We can't do it that way. So we have our challenges ahead of us, but we have to go to in that direction very much to solve this one-to-many need that we have. So it's our opportunity really, now that it's on everyone's mind, to reimagine healthcare delivery entirely. And I like the analogy very much of the when I've looked this up. This is an interesting story that when Alcoa invented aluminum, people didn't quite know what to do with this new material, strong, light, but very unfamiliar. So they ended up painting a lot of things that were made of aluminum to look like wood so that people would be familiar with the material. So you see coat racks made of aluminum painted to look like a wooden coat rack. And that's an analogy I like very much about where we are in terms of telehealth and digital health and healthcare delivery, is we're trying to take a construct that we felt really comfortable with in the analog world, the office visit, and move that into the digital world. And that's great, but it really isn't reimagining how we can deliver care using these tools. What it does do, though, already, and again, I think we're only at the beginning of the journey, it does force us to rethink how we use brick and mortar. And that's a lot of what we're up to. This is a rendering from a building that we're planning to build at the Massachusetts General Hospital. And I know that all the senior executives at our organization across the system are now contemplating, what does it mean to have 25% of your ambulatory activity done remotely? I sit here on Tuesday afternoon, and I'm actually delivering this talk to you from a bedroom in my home, and I'm going to do telehealth here in the afternoon. That changes the overhead equation. That changes how we think about how we outfit our brick and mortar. It changes the way we think about how we bill for facility fees. It's a pretty big deal. And that, I think, is the major thing that we all have to wrestle with. What do we need to bring patients in for? I'll give you another example of a change that I've seen. Prior to the pandemic, I used to get very little attention from my colleagues in orthopedics because they viewed themselves as needing to be with the patient to do what they do, which is of course true when they're doing surgery. But since the pandemic, I've heard them say, oh my goodness, I can do pre-op virtually. I can do post-op wound checks virtually. We can do rehab, physical therapy virtually. And all of a sudden they're rethinking completely which patients need to come into the facility for what. And we have to go through that specialty by specialty. And it's going to be an interesting journey for sure. So this is a little bit of reiterating, but optimizing the use of the physical plant, rethinking overhead, workforce implications. We can bring new people into the workforce now if they can work from home, people that are either stay-at-home moms preferentially, or perhaps semi-retired or retired workforce can come back in and do shifts without leaving their home. That's interesting. And of course, payers, as I alluded to earlier, are really quite afraid. And so we're going to be seeing more dialogue around this. They're worried that we're going to substitute rather than make it additive. And they're worrying that, they're worried that we're going to make it additive rather than substitute. They're worried about how to manage the increase in access. Does that really lead to an increase in cost? Keep cost in check. So my opinion, personal opinion, is that we really need to work with them to try to solve these problems so that we don't throw the baby out with the bathwater and simply have them say, no, telehealth adds too much access. It's too much of risk for us. We're not going to pay for it. I think that would be an enormous step backward, and we owe them the dialogue to work through that, in my opinion. Reimagining healthcare is really about a fully integrated digital and in-person experience. I, again, like the analogy I mentioned early, Uber. You do all of this front-end work by establishing a profile and whatnot, and then all of these interesting technologies from GPS to payment systems work on the back end to make your experience seamless. Your service is delivered by a human being, but the before and after is seamless, and your level of work is low. I think that's an example of where we need to go in healthcare delivery. Another one I like is if you go into any Target or Home Depot, there's an area where you'll have one person for 5 or 6 cash registers. You've all experienced this now. If you need that person's available. But if you don't, you quietly check your materials out and leave. When you go to visit your doctor, chances are you'll see 5 or 6 people before you see your doctor. So we just have a long ways to go in healthcare and sorting this one-to-many model out. With that, I'm going to leave you with my contact information. If there are questions, I'm delighted to entertain them. And I thank you very much for inviting me to share these thoughts.
That was great. Thank you, Joe. A lot to ponder. Obviously, there's a lot going on in the background, and you know, the regulatory environment obviously is a huge issue that's we're going to be wrestling with for some time to come, I think. I had one question, and my sense is that you are speaking mostly about the adult patient world. Does this also apply across the world of pediatrics, or do you see challenges adopting as broadly in the pediatric world?
Well, I don't have firsthand experience, but I have anecdotally heard a lot of pediatricians are doing a lot of work virtually. I think it's a little bit maybe analogous to doing home virtual classroom, in the sense that you have to have the parent involved, and there's some perhaps a little more complicated, but I think other than that, there's been a lot of movement virtually in pediatrics, and I think it's a big part of this future. So I would say count on pediatrics being a big part of it.
Okay. Any other questions? Let's see here. I see one popping up. Have you seen how telehealth has impacted physician burnout, either relieving or exacerbating it?
Yeah, thank you for the question. I think candidly, during the public health emergency, it probably added a bit to burnout. Of course, I'll say that I remember myself during those dark days from mid-March to the end of May, it was tough. As much as I'm an evangelist for this care model, I love seeing people in person. I love interacting with patients in the office. So I think that was hard for everyone. It was like flipping a switch, and overnight you had to do everything virtually. And so people who weren't prepared, I'm sure, felt somewhat discombobulated. The other side of it is that as we ease back into the hybrid model, I alluded to this in our practice, is that we've carved out time for every clinician to do a couple hours a week of telehealth or more, if depending on their interest in their patient population, but at least a couple of hours. So that's added work, added touches to Epic, added messages from on the in-basket side, et cetera, et cetera. So I think it has the potential. The flip side is, if I do, for instance, and we didn't really talk about e-consults, but one of the popular tools that we use is a primary care doctor in our system can put in a couple of images of a patient and a few sentences of history and get a specialist opinion. And again, in my case, it would be a dermatologic opinion. And when we do those efficiently, we can do, I don't know, maybe twice as many per hour as we can see patients in the office. So that means you're adding my visual expertise back to the care process twice as efficiently. And so I think if we manage our expectations of clinician work and we lean in and really explore more of those efficiency models, we can equilibrate it to a way that it helps with burnout. But now we're just in the beginning, and it's, I think, a little bit, it needs a little bit more refinement before we get there.
I have one more question, Joe. How do you think this technology will impact residency programs?
So great question. So we've included residents in all of our telehealth activities to date. Again, this is, so I didn't really talk about this, but when I talk about the behavioral health use case, there's a lot of people who've developed evidence and feel strongly that it's probably better for behavioral health. Why? Well, because I get to see the patient in their own home. So they're more comfortable not leaving their home for service, and I can get to see all things around them that may contribute to their condition, which I wouldn't get to see in the office. And the analogy in training doctors and nurses is that if I can sit next to a doctor in training and watch them interact with a patient. Now, when we do that in the office, it's very awkward. You're standing in a corner while the trainee does their exam and their history. It's called an OSCE. That's the way we evaluate trainees, but it's very awkward and very artificial. We sit down in front of the computer and we're already talking to the patient together. It's not awkward at all. It just seems seamless, and I can really understand how that clinician in training is dealing with the situation from many perspectives. So it has a potential to really help with training. The more we get into the asynchronous, the more we get into some of the other modes of care delivery, we probably have to rethink some of our competencies and whatnot. But I think it's very positive overall.
Good. I don't see any other questions, Joe, so I want to thank you very much for joining us this morning and giving us a view from a perspective that is very rare, and that is of somebody who's been working in this field, as I said, for 25 or more years. And I think we're all excited, both as patients, to explore what is and is not possible through telemedicine, but as architects, I think we're also obviously wrestling with what the physical and spatial implications are of adopting this technology in our facilities. So thanks very much, Joe. You're certainly welcome to stay
and happy to get email traffic from anyone who has questions as well. And thanks so much for inviting me.
Great.
Thank you very much. This is Stan Hunter again. Very, very interesting and profound information, and really exciting to see where this goes over the next as we explore new buildings and new projects, and the type of dialogue that creates in all of our projects.
Very much.
The next piece I'm going to hand over to Teresa Wilson to introduce the panel and the discussion that we will have from here. Thank you so much.
Hi, everybody. Thank you for joining us, especially Dr. Kavita. That was really an interesting discussion, and I'm going to be forwarding some questions I didn't get to ask. What we want to do today is have a conversation with a group of people who come from different parts of our community. Paul Bittinger from MGH, and I'll ask each person to introduce themselves a little bit more. Walter Armstrong from Beth Israel, Deaconess Medicine. Alan Ames from BR+A, and Kathleen Lane from Shepley Bullfinch. But before we start, I want to just give a brief overview of HIO. I think most of you know about it. It started in 2013, and we originally looked at how to design inpatient bedrooms to reduce the possibility of infection. We did a project at Brigham and Women's Hospital. We had started one at Newton Wellesley, and we've got a great start on that. But when the pandemic started, we turned course a little bit and started to look at how we as a community could offer our services to help what's going on right now. We've had 9 meetings, and we've done some really incredible things. A lot of the people who have participated in HIO have now are also working with the Facilities Guidelines Institute. They have an emergency committee, which is putting out a white paper in about a month, addressing all of the things we've been hearing and more. It's a very detailed section. And what's great is a lot of the information that we did for post-acute care is actually making it into the white paper draft so far. So there's a lot of really great work that we've done, and we are offering our services again. If you have anything that you think would be useful for us to focus our attention on, we'd be happy to look at it. We did it with waiting rooms, we did it with post-acute care, and as we move forward, everybody please think about what would be a good use of our expertise. I'm going to start with Dr. Bittinger. If you could go a little bit into your background for the group, and then I'm going to just pose 2 questions to you and Walter Armstrong, and then we want Kathy and Alan to jump in with some conversation about just what we're implementing in the long and short term for the current situation we are with the pandemic, and how operational procedures are happening now with this dual reality of COVID and non-COVID care. And first of all, where are we? Are we in the second wave? Are we still in the first wave? If you could both talk about that. But I'm going to start with Dr. Bittinger.
Sure. So good morning, everyone. It's a pleasure to join you. My name is Paul Bittinger. I am an emergency physician by background with a specialty in emergency management and disaster preparedness. And I am the medical director for emergency preparedness at Mass General, and for the Mass General Brigham system, I oversee the emergency preparedness programs and have led our response to COVID-19.
Walter?
Hi, Teresa. I'm Walter Armstrong. I'm Senior Vice President for Capital Facilities and Engineering. I'm trained as an urban planner, and most of my career has been in managing large-scale capital programs or capital projects. At BIDMC, I'm the Senior Vice President for Capital Facilities and Engineering, as I said, which has a whole gamut of things, including the COVID-19 response.
Alan, you want to give an introduction of yourself?
Sure. Can you hear me okay?
Yep.
Okay, good. Alan Ames, president of BR+A Consultant Engineers. Although we're kind of based in Boston, we have offices across the United States, and we work locally and internationally. Currently working on projects at BI Deaconess, Mass General, Children's Hospital, but also places like Ohio State, VCU, and other places across the country. Also have a specialty in proton therapy design, and have seen the full-blown gamut of things that have been implemented related to the COVID crisis.
And Kathy?
Yeah, hi, good morning, everyone. I'm Kathleen Lang, so I'm a principal at Shepley Bullfinch, and I've been working in Boston as an architect since about '86, primarily in healthcare. And I've been with Shepley for 20 years.
Great,
Thanks for
thank
the
you.
invite, Teresa.
Oh, you're welcome. So just a quick introduction of myself. I'm Teresa Wilson. I work with Colliers Project Leaders. I have a background in architectural healthcare, and I've been working with HIO since probably 2015. So it's been really exciting to see how it evolves. Dr. Bittinger, can you just talk a little bit about where we are right now in this moment in time, and so
Sure.
we can understand where we need to go?
That's potentially, obviously, a huge question. I'll do my best.
Yeah.
I think for those of us in the Boston area, I think we are in what probably can best be described maybe as the steady state. We obviously had an enormous wave of COVID cases from March through May or so. But since the beginning of July, give or take, most of the hospitals have been at a relatively steady state of admissions. There is COVID in our communities. There are some hotspot communities that have more community prevalence than others. But in terms of the number of people either visiting the emergency department or being admitted to the floors or the ICUs, it's been relatively steady. And barring additional waves, I think that's what we should expect to see until at least there's widespread dissemination of a vaccine. I don't think it will go lower. There's a lot of risk of it going higher. And I think there are some things that are somewhat different here in New England than maybe in other parts of the country. Factors that argue for a second surge include just people being indoors more, very relevant to this discussion. We know that the indoor environment is much different than the outdoor environment. And so when people stop throwing backyard parties and move them indoors or others, I think there's a risk there. And so the cold weather plays a role. Certainly schools with people coming together in physical space more than they have before plays a role as well. And I think fatigue with some of the masking and physical distancing restrictions plays a role as well. So thankfully here in New England, our community adherence to some of the recommendations has been quite good. And I think that's played a huge role in where we are. We don't yet know where we are with the change in weather. And if outdoor dining becomes indoor dining, that may change things as well. But this is, I think, the world we can live in, that we will live in, with the exception of potential additional surges, which may be likely.
So Walter, we had an interesting conversation last week, and one of the things that you said that really struck me as interesting is that you know a lot more now. You've lived through this extreme experience, and you've made it this far. How does that work with providing typical care with pandemic care, or how you would handle a future surge? Do you think? I'll just leave it at that.
Okay. Well, I think there were a number of things that were big challenges with COVID-19. And like Paul, I hope we are in steady state and not in lull before the storm. But we are preparing for the next surge. And if you look at our challenges, supplies were a very, very big challenge. And so we have moved, as I assume most institutions have, from a just-in-time approach to getting our supplies to actually locating and renting warehouse space closer to campus where we can build a supply of scrubs and face masks and shields and all those things that we were scrambling in the national and international supply chain to have. So not only warehouses, but we continue to take our conference rooms offline. We took them offline, we're leaving them offline. They become spaces to store supplies on site. Another challenge was finding locations both on the main campus and on off-site ambulatory facilities to test and evaluate whether patients had COVID-19. And those tents have remained, the off-campus sites, the tents have remained in place. We're looking at how to winterize them. We're perhaps replacing them with trailers. On campus, where we built facilities, like in the lobby in the building that has our ED, we have left those evaluation sites in case we needed it again. The other challenge was, I think we expanded our ICU capacity by, I don't know, 2.5 times. And we know where those spots are. We are ready to jump back with HVAC changes. I won't make HVAC comments with Alan on the panel.
We'll get to him.
But we know where those spots are. And in fact, you know, we gravitated towards the PACUs, which was good for efficiency, but maybe put, you know, a very, very big dent in our ability to do surgery capacity. So maybe we are looking a little more carefully now on which med surge floors are more ripe to convert to negative pressure and make them ICU floors. And the last comment I would make, because it's analogous to the first speaker, if the Band-Aid was ripped off telehealth, I think for our institution, the Band-Aid was ripped off remote work. And that really, we are really going through a very thorough evaluation of what our offsite administrative space needs are. I mean, which people can work remotely a large percentage of the time. I have a bias that if you're a remote worker, you still have to come to the office a certain percentage of the time, but how does all of that work? And I know a number of the HAIO members have done designs about how the modern space would not only have the appropriate COVID-19 distancing, but really incorporate the kinds of touchdown space and conference space that's going to be needed in the new normal for administrative space. So that's some of our thinking so far.
And maybe I could just jump in for a second. Walter,
Sure.
we're seeing the same thing, is that a lot of the engineering staff, not necessarily the operations staff, have been remote, and they've been able to get into their building automation systems, their electrical systems, and able to see what's going on and troubleshoot them remotely. And it's become a bigger and bigger part. Even though the operations staff are still on campus, we're seeing the engineering side being able to work remotely.
And Kathy, do you want to just talk about the flexibility of
course, yes.
situations?
I did want to mention something. It's so interesting what Walter said about just-in-time delivery, because I think of all the years that so many of us worked with our clients about lean, right? With trying to leading our operations. And I can only imagine what, you know, just-in-time delivery did to you, and especially in regards to supplies during this pandemic. So it'll be interesting to see how, you know, what kind of a compromise we see in the future regarding lean methodologies in healthcare. I'm sure there's a compromise. I'm sure it won't go away, but it's interesting. I was going to say flexibility. I think that's the thing that we're just going to have to consider more and more. And that can mean so many different things. You know, we talk about flexibility for years. But, you know, what does it mean to a system that has several hospitals? Could it potentially mean that a couple of hospitals within a large system will become pandemic hospitals should that need arise? Or, you know, more similarly to what I think we all have been seeing, will you see hospitals have the flexibility for a few units or a few floors to be negative? And I know Lou Fasson from Yale New Haven Health has joined us this morning, but several years ago with the Smilow Cancer Center, it was time of SARS. So I believe maybe even during construction, we changed the HVAC system so that 3 floors of a new bed tower could go negative in a pandemic. And I think that became their workhorse floors during COVID-19. So that, you know, that's part of the flexibility. But I think you also have to look at med-surg rooms. Do all med-surg rooms get designed with, you know, power and med gas to treat ICU patients in a surge situation? do those rooms be just slightly larger to accommodate 2 patients rather than, moving those patients to non-inpatient spaces where, sports spaces aren't necessarily available. So I think there's just a lot of things that we'll be looking at, and that we'll be asked to look at, especially as projects, now become more and more active again.
If I can, I might build on that. I couldn't agree more with that comment. I think that's actually been really a lot of what's been driving the design of our planned new building at Mass General that you saw on Dr. Creator's last slide. It will, by design, be the most resilient building on our campus. And so every single room has a double head wall for us to be able to evacuate into the building in a disaster situation or surge as a facility of resilience. Parking garages can become storage sites because, of course, with just-in-time inventory, we don't have a lot of place to store things. And especially when we have an anticipatable event like a hurricane, having the ability to stock up in advance is really important. Looking at stock rooms to see, again, what inventory we might be able to keep is extremely important. But I'll tell you from our own experience in COVID, we had built double head walls into our emergency department rooms and ended up needing to use them during the worst of the surge. And it was our general care floors that were built with an eye to flexibility to be able to surge in intensive care that allowed us to do exactly what Walter described as well, is those were by far the best suited rooms to provide critical care because they had that space, that design, that flexibility.
So as you're designing it now, you're able to accommodate that. And Walter, as you look at new spaces, are you looking at those things? Are you also providing spaces on the exterior for utility hookups? Are those parts of the things that you are considering as you look at new or renovating spaces?
Yes, we are. The exterior hookups, some we had on buildings, and then others we have created. We're definitely looking more at the flexibility of spaces. But one thing that strikes me as we take a different view of what we're going to do with our HVAC systems, it's going to conflict with our goals and with city and state goals about environmental sustainability, right? We're all trying to get the most energy efficient buildings that we can in our new buildings. Yet I don't hear our infection control people make any suggestion that would resonate with energy efficiency.
Right.
So balance, the word that Kathy used, will be a good word in how we design and move forward and try to make that thread that needle between energy efficiency and the kind of air systems that we might need to be prepared for future pandemics.
Right.
Hey,
And
Alan,
we've been seeing the movement downward in air change rates from outside air percentages for patient rooms, and it's kind of anti-COVID in some ways, where most people want 100% outside air systems as compared to recirculating air systems. Also been seeing movement towards better filtration levels, which is anti-sustainability, because higher efficiency filters have higher pressure drops, higher horsepower requirements. So to counteract that, we've been increasing the size of the equipment, which causes the cost of the healthcare facilities to increase. Adding in all these different components into the health, like additional head walls or additional flexibility, making rooms being able to go positive or negative. That also, the control side causes cost increase. So it's been a balancing act. We're seeing the cost of healthcare approaching $1,000 a square foot for new facilities, and it's a trade-off. You have to look at every single thing when you're designing it and make a determination what's the most important. And that's generally not up to the engineer. It's usually up to the healthcare system that determines that. Another thing that we've been seeing is people are starting to look at how people enter their facilities and the flow of people and the security side of things, and whether or not they need to have a queuing area to make sure that the the people are non-COVID entering the facility and are checked in and stuff. In the old days, people could flow through healthcare facilities unimpeded pretty much. And now it's changing. We're seeing people rethinking that whole thing. So there have been a number of changes as a result of this crisis that are, everybody's trying to figure out what the right thing is for their particular facility.
And we have a couple of questions on the chat section. One was, are you seeing design of inpatient units with grouped isolation rooms, either pods or whole units, to minimize donning and doffing PPE? And can you also talk about the need for anterooms? There's two separate questions, but I think they're complementary questions.
I'll answer the first from what we are seeing. And truthfully, this was pre-COVID as well. But we were definitely seeing requests for clusters of isolation rooms, or even, let's say, the ability to have a negative pressure suite within a typical med-surg or ICU space. And those requests were coming from infection prevention. So I imagine those requests will continue to come, but there will only be more and more. And I also, I don't want to forget behavioral health, because in speaking with client at North Shore Medical Center, we had finished the 4 floors of behavioral health units very recently. And what they had to do was essentially cluster off a group of behavioral health bedrooms on, I'm not sure if it was 1 floor or all 4 of those floors, say maybe 5 bedrooms. The layout allowed that to happen, put up temporary barriers, and then those spaces could be used for, say, the asymptomatic mental health patient. But frankly, that was something, we didn't think about that during the design of the space.
Yeah, and we're also hearing about separate paths of entry for symptomatic and asymptomatic patients during care. Dr. Bittinger, could you talk about that a little bit?
Sure, and I think obviously there's so much complexity and quite obviously controversy in a bunch of this. I think, with respect to COVID, separate paths of entry are challenging because of the percentage of patients that are asymptomatic. The thought that at a moment of entry we can identify everyone who is potentially infectious just is not true with COVID. And so I think we have to have good universal screening plans, as I think were addressed before. Now, there are hospitals, we're doing this as well, that are pursuing special clinics for either those that are symptomatic or those with a known diagnosis. So we have patients with COVID who still need to get follow-up for dermatology or orthopedics or other things that have been mentioned. And when we already know there's an infectious risk there, having a special path of entry, a special site for evaluation of those patients in an ambulatory setting is absolutely important. I think, the issue, the anteroom question, the negative pressure room, is a really important question. I'll say that across our system, we actually developed with our engineers and other experts a healthcare facility blueprint for how we would and would not go about some of these airflow and other modifications. I think, again, I recognize how much controversy there is, especially in the last few days, about the use of the word airborne with respect to COVID. But our own internal evaluation of the safety of our environment shows that caring for patients in non-negative pressure rooms, with the exception of AGPs, aerosol generating procedures, and as long as we wear the right PPE, is extraordinarily safe. And so there's not necessarily an evidence base to try and push 100% outside air, which really, frankly, for us won't be sustainable for temperature maintenance in the middle of winter. But I also think, in my world, emergency management, there's always the danger of planning for the last war as opposed to what's coming in the future. And there are diseases that, in fact, are more transmissible through the airborne environment. Measles is a great prototype. And so I think in any future state planning, not to be planning for what we went through, but what could still happen. I think the need for proper airborne infection isolation environments, and that includes anterooms if we need to be donning other PPE, is still a significant need, no question.
Walter, have you had that same experience of thinking about adding those to your entry and exits to your?
I think in the past, as we had faced some of the previous pre-COVID SARS, Ebola anterooms, the ability to have anterooms was always considered a big constraint in our older buildings. I think our new rooms or our rooms being planned for our new building have much more space, much more areas that can be segregated in that way. But yes, I think on the existing campus, it's always been a constraint as we've looked at how we might deal with those other illnesses that have passed through over the last decade. Obviously, none of them have had the reach of COVID-19 and the number of affected patients.
Alan, do you have experience that you could share about that with the anterooms, what you're seeing?
Yeah, generally there aren't as many healthcare facilities that are being planned with a large amount of anterooms. Usually they're isolated, so they're segregated in a certain section of the facility, and we're not seeing them implemented on a widespread basis. So it's just probably because it costs more money to build them, and if you take it and multiply it by 30 on a floor, 32 on a floor, or something like that, the costs tend to rise up, and they don't get used as often as they might be on regular patient rooms. So but the things that we're seeing is everybody's looking at the disinfection side of things and what you do to clean the rooms after the patients leave, and whether or not there's a UV light requirement or a VHP requirement or something along those lines to disinfect the room and clean them afterwards, and making sure the materials in the spaces are adaptable for that type of decontamination cycle. But the anterooms is, we've seen more movement towards negative pressure rooms, the ability to switch from neutral or positive to negative, and have the control side of things, which is, a relatively inexpensive thing to do because of the ability for the control systems to handle that type of change.
So we actually had a brief meeting yesterday with a couple of the other engineers from BR+A who we work with often. So that was Steve Levin and Mark Apria. And, they were talking to us and showing us some plans for a clinic, a simple, simple clinic, outpatient clinic, off-site. They had redesigned, or they are in the process of redesigning the mechanical systems. And in the waiting room, they're putting in low returns. So it's almost, I don't want to say it's like an OR, it is not like an OR, but just in terms of the airflow to get the proper airflow and to get it out of those spaces, those waiting spaces via the low return. And there's a very careful coordination, of course, that has to be done with the seating, or else you'll have, bad air is not the right, please, it's not the right expression, but you'll have, say, potentially contaminated air going right over certain patients, depending on where they're seated. So that's a great idea. But I was thinking about, 1 year from now, 2 years from now, when some well-intentioned person starts moving the seating around into what they think is a better, a better layout. We just have to, that's a very simple example, but for all of these, we just have to consider the operational, how to record, I should say the correct operations, so that the staff, whether it's, the person at the checkout desk or the person in the engineering office, knows 1 year from now, 5 years from now, how these systems all work.
Right.
And that we don't, someone doesn't unfortunately do the wrong thing. So
well, that brings me to a point that FGI has been talking about, is communications during an emergency. And you may have people working in units where they're not familiar or not understanding the risks of entering certain rooms. Dr. Bittinger, have you had conversations about that? There's been some talk about, creating standard colors for warning systems or using LED lights, things like that. What's your experience been?
So we've definitely found that it's an issue. I think that operational comment was spot on, and I think in planning for these spaces, you really have to have your clinical staff as well as your infection preventionists and preventionists and all of your engineering experts as well. If you make a whole floor negative as a common airspace, then everyone, including the administrative, the support staff, have to be wearing respiratory protection in that space. And it's not always clear that people sort of understand the implications of creating a common airspace for infectious disease with respect to what the workflow is in that space. So we've had a lot of discussions about when that's desirable and when that's not desirable, or when there are relative gradients, say, between the central work area and the individual patient rooms that make the central work area safer. So we've been doing it with manual signage. We haven't really found a solution that works well, but I think it's extremely important, definitely in the rollout, but also in the planning. I think two particular areas of concern I would call out have been in the emergency department setting, where trauma rooms by code traditionally have had to be positive pressure, like an operating room environment. And that's just not ideal in the setting of an infectious disease pandemic, where we've had trauma patients come in asymptomatic who end up having COVID. The other is the need, and forgive me because I always get this term slightly wrong, but is the combined protective environment room, that we have immunosuppressed patients who should not be in a negative pressure room yet have risk of COVID and need an aerosol generating procedure. So of course a hybrid positive negative room is that is switchable is not allowed, but the hybrid rooms that allow for negative pressure, but it's a protected environment space nonetheless. We're looking at, very, very few of those exist, and we're looking at how many we might need going forward.
And Walter, there's a question I thought maybe you could answer this. How are you handling staff support spaces right now, staff lounges and break rooms, to allow people to eat without PPE and have some respite time during these emergency situations?
That is a really great and relevant question. We have actually sent out a communication yesterday to people reminding them about social distancing and how they lay out in terms of spacing in the breakout room. So we have tried to reorient the room so that we can maintain social distancing. We obviously, not unlike restaurants, encourage people to have their masks on when they're just, have finished their meal and they are just chatting. But it is an important issue. It's one that, as I said, we keep tinkering with and trying to make sure that people understand the environment, understand the rules, understand the requirements, but it's not an easy issue.
Teresa, I'm just going to do a time check of about 5 minutes left. And so thank you. If you want to keep going, thanks.
If I can sneak in one quick comment to build on Walter's, I think we have absolutely seen in the data that staff eating and drinking together is one of the greatest risks of workplace transmission of COVID. Despite what our infection preventionists have said for years across healthcare, most nurses, physicians, others try and eat at their workstation. I think there's a real imperative, certainly in my system, there's a real push to try and find close by safe spaces where people can still hydrate, can still take down their mask and eat and drink. But the traditional small break room in the corner of the unit is just not sufficient, and we have to look for alternatives.
Thank you. Alan, I have a question. Everybody knows terms now that they didn't know, MERV, PPE. Are you finding that as you're meeting with people and clients that you have to kind of back off or educate people a little bit about these terms that are new to them, but that you've been dealing with for a long time?
Yes, the MERV levels are something, and I could actually share my, if I could share a screen. There was an ASHRAE, let me see what I can do here. Is that
Yeah, I
it?
don't mean,
How do I
we
share
have
it?
just a few more minutes.
Anyways, so there is an ASHRAE guide, a web page on ASHRAE. It's under the technical resources side that answers questions about MERV filters and what each filtration level means and how often you should change them and the recommendation for disinfection and things like that. It also talks about UV lights and which ones are relevant to a healthcare setting. But yes, the terminology of air change rates and MERV and all the different things that we normally talk about from an engineering standpoint with the engineering staff has turned over into the general population of any of the healthcare design projects that we're working on.
So one of the aspects of that is, explaining that there's cost and environmental impacts for these situations. And I think that's got to be the conversation that everybody has when we're talking about these ways to handle this new situation. I think we have just a few more minutes. Dr. Bittinger, if you have anything else that you want to add to the conversation?
I want to obviously thank you for bringing together this discussion. I think this is so complex and there's still much more we have to learn specifically about COVID. I think the challenge is a lot like what we had on the medical side of COVID, where we've sort of swung back and forth among different options as we've put the data together. And I think there are competing interests about the cost, about the energy efficiency, about our contribution to global warming of our buildings and our obligation to have safe care spaces. So I think part of what we're trying to do is make sure we act on what we know now, but we also reserve some of the major actions for the lessons that we're going to be learning in the next couple of months and beyond.
Great, thank you very much. Walter, do you have anything else you want to add?
I guess I just want to compliment your group and all its members, the architects, the engineers, the constructors, who I think reacted so quickly. Boston is really fortunate to have the talent that it has, both in terms of the crisis response, but also, as Paul has said, in thinking about how our spaces need to look in the future. I mean, the work has been great. I know you have posted it and it's available nationally,
Yep.
but my thanks to everyone involved.
And Kathy and Alan, anything you guys want to add? Kathy, you're muted. Couldn't have a meeting without that
It
happening.
happens at least once, I know, really. I think Paul had mentioned something earlier that very much resonated with me. It was something we were also talking about yesterday. It would be such a shame to start investing millions of dollars to combat only the COVID-19 virus. And I'm not a virologist, so I don't exactly know what is the next thing that could be out there. But I think it's worth a conversation so that we could look at potential future solutions just a little bit with a wider lens.
So keep your eyes and ears open for that FGI white paper. You might have some information you see in there.
It would be nice if we could get everybody together and kind of agree upon what the next step would be in the design of future facilities, and with an eye towards the budget and an eye towards the energy consumption of buildings, and not overreact, but do the appropriate reaction. But it's hard to tell, because like when this started happening, a lot of people thought it was going to be like SARS, and it kind of disappeared initially. Like it showed up on the West Coast and then disappeared, and it obviously didn't. And luckily, a lot of the facilities that had been designed in the SARS era were able to adapt to it quickly, because they had things designed into them that allowed the engineering staff and operations staff to adapt to those. And my guess is that that's going to happen from this and may be applicable down the road, but who knows?
Great.
Well,
Thank you.
I want to thank everyone for your time. And Stan, did you want to?
Well, thank you, everybody on the panel. Dr. Kvader earlier, John Meservey and Richard Barnett, on behalf of everyone at HAIO, we thank you, and we look forward to a next session that we will plan on for roughly 5 to 6 weeks out from now, and look forward to that continued discussion, and also more other participants from healthcare providers and other members of the regular members of this whole group. We opportunities for others to participate. So thank you very much for this, and we look forward to continuing these discussions. They've been very, very informative and productive, and towards our goal of creating a information sharing and commonality in this era. Thank you very much, Teresa, or Richard or John, if you have any last comments. Otherwise, we can sign off.
Just say thank you, everybody, and see you again in 5, 6 weeks.
Thanks.
Yes, thank you very much.
Great. Thank you. All right.
Yep.
Bye-bye.